So we have previous speaker, Dr. Prakash, who is
Good
ready
evening to
talk.
everyone,
Please.
and greeting from Bangladesh, and it is great honor for me to talk in front of my mentor, Basavada sir. So in next few minutes, I will be talk how to deal the cataract with the incomplete axis. Though anterior capsular tear is relatively uncommon complications, occurs less than 1% of phacoemulsification procedure, as mentioned in the literature. It has some potential complications like posterior capsular gland, nucleus drop, and vitreous loss when the rex is extended behind the equator. So the anterior capsular tear occurs at any stage of the phacoemulsification procedure. Here we can see it is a white intumescent cataract, and the rexes run out spontaneously at periphery in both directions due to the high interlenticular pressures. Here, after making the main port, I was extending the anterior capsules with tip and blow, and during replacing the tip and blow with the viscoelastic substance, here I can see the rexes run out into periphery. When and how it occurs, I could not figure out. Here, rexis was complete. It was a white cataract, and during rotations of the nucleus, rexis ran out into the periphery. And it was a hard cataract, and I was doing this single-level vertical chopping. And due to excessive separating forces that transmitted to the capsular bag, that causes rexis tear superiorly. And here we can see the phaco proof there is a tear in the anterior capsules, and during chopping, it extends into the periphery. Here, due to excessive bending of the irrigating aspiration handpiece, there is a rexis tear occurs during the removal of the cortex with the bimanual IA. In this clinical video, we can see during polishings of the anterior capsules, the rexis tear occurs. Here, during IOL implantations, the rexis tears occurs. Here, during removal of the OBD from behind the IOL, we can see the rexis tears occur. So rexis tears occurs at any stage of the phacoemulsification procedure, and the further management depends on the surgeon's experience, type of cataract, locations, and time of the tear. Principally, there are three choices: conversion to extracapsular extractions, anterior chamber phacoemulsification, and endocapsular phacoemulsifications. Endocapsular phaco is still possible with some surgical pulse. First, convert the split anterior capsules into circular as much as possible to reduce the tractions on the remaining capsular bag. Hydrodissection should be gentle and judicious. Here I am doing the multi-quadrant hydrodissection with a small band hydrocannula. Every time I am injecting very small amount of fluid, and after every inject I decompress the nucleus. Otherwise, forward bulging of the nucleus that can causes further extension of the rexis tear. And during nucleus rotation, should be careful to avoid tractions on the capsular runout. And anabdib sculpting is the prerequisite to divide the nucleus into multiple small fragments. Using more ultrasound with low irrigation pressures, low and corresponding low aspiration flow rate is the crucial, and to avoid the stress on the zonules. And chopping should be done very carefully with high vacuum and low aspiration flow rate. Here I am using a stop and chop technique to divide the nucleus. And complete anterior-posterior divisions of the nucleus is very crucial to emulsify the fragments into the posterior plane. During fragment removal, it is very important to use optimal fluidic parameter to maintain the stability of the anterior chamber to prevent further extension of the tear. So we have to always keep in mind the input should be matched with the output. And the slow motion phaco with the torsional ultrasound is very useful to deal the cataract with the incomplete axis. The main advantage of the torsional ultrasound, it has outstanding cutting efficiency, and there is no conflict between the energy and aspirations, and it greatly enhances the followability. Even with the low aspiration flow rate, the fragments are coming to the phaco tip very nicely. So it is very useful to deal with the cataract with the incomplete axis. And it is very important to inject dispersive OD through the side port to take care of corneal endothelium, because the dispersive OD has more negative molecular charge than the cohesive OD, which is better absorbed by the positively charged corneal endothelium. And it is also important to inject OVD before take out the phaco probe to maintain the stability of the anterior chamber to prevent further extensions of the tear. And it is also equally important to take care of posterior capsules, and one option is step-down technique, another is IOL scaffold. In step-down technique, which is taught by Basavada sir, when more and more fragment is removed, the posterior capsules remain unprotected. So it is wise to progressively reduces all parameters proportionally to take care of posterior capsules. In this case, in the IOL scaffold technique, I first maneuver the remaining lens fragments above the iris. Then I implant the single-piece foldable IOL into the back to the existing corneal incisions. And then after injecting some dispersive OBD over the lens fragments, I take out the remaining lens fragments with the Phacoemulsification. Here I first implant the foldable IOL into the back. Then with the visco expression, I take out the remaining lens fragments. And flap motility sign is a very important sign to assess the peripheral extension of tear, which was described by the Rohit Om Prakash. If the flap is everted and flattering, that means it is pre-equatorial, so the continuous phaco is the shape. But if it is inverted and non-flattering, that means it extends behind the equator. In that case, it is not wise to continue phaco. And bimanual IA is a better option than the coaxial IA, and it is wise to aspirate the cortex first away from the rhexis tear in a tangential manner, then around the rhexis tear. Because bimanual IA has negative and both irrigation and expression can be separate, so it gradually maintains the chamber stability. And single-piece foldable IOLs can be implanted into the back, but the haptic should be oriented perpendicular to the rhexis. Here we can see there is a rhexis tear occurs, and at one point I have seen there is also PC rand. So I proceed to implant a multi-piece IOL into the sulcus and then take out the remaining lens fragments. Same thing happens over here. There is a rhexis tear, and when rhexis tear occurs, after injecting the dispersivity through the side port, I take out my irrigation handpiece. Then with the very low inflow and low aspiration, I proceed to aspirate the cortex from the other side. Even then, there is you can see over here, there is a PC rent through and through. So here I decided to implant this foldable IOL, single-base foldable IOL. I first place the IOL into the anterior chamber, not directly into the back. Then through the side port, I first dial the one haptics and dial it into the back, and with the same technique and dialer, I push the other haptic into the back. And thorough removal of the OBD is very crucial to prevent the postoperative rise of intraocular pressures. And it is wise to keep inflow very low initially because there is already some OBD there to reduce the pressure of the anterior chamber. And when more and more OBD is removed, then gradually we can increase the bottle height. It is a white intumescent cataract. Here you can see the rhexis tear occurs, and a tangential cut is given, and the rhexis is converted into the circular with the micro-rhexis forceps through the side port. And the phacoemulsification was uneventfully remove the cortical matters, and every time I inject the dispersive through the side port to maintain the stability of the anterior chamber, and bimanual IA is a very good option to take out the cortex from the capsular bag. And after injecting the cohesive OBD, implant the IOL. The main advantage of the cohesive OBD, this is long chain molecule and highly entangled with each other, so they can easily remove from the eye. This is again another case. You can see to maintain the stability of the anterior chamber, I was doing the rhexis through the side port to the micro scissors. But even then, when it was run into periphery, so with the same technique and same principle, I give a cut into the anterior capsules and enlarge the rhexis size. And with the slow motion phaco, using the low parameters, I take out the lens matters and injecting dispersively through the side port and implant the IOL into the back. Thank you so much for patient sharing.